Without further ado, I'd like to introduce my friend and colleague of many years, Dr. Gail Cassell. She's got a long list of impressive accolades in her career. She's currently the Vice President of TB Drug Development at IDRI. She's also visiting professor in the Department of Global Health and Social Medicine at Harvard Medical School. She's recently retired Vice President at Lilly, where she worked on drug discovery. She was the head of drug discovery, and more importantly, she was responsible for launching the Lilly Mdr Tb philanthropic effort. She has a number of positions that are impressive, including being the chairman of the Department of Microbiology at the University of Alabama School of Medicine in Birmingham. She sits on many panels. She also sat on snowy train rides, overnight train rides with me earlier in my career when we tried to produce capreomycin, a drug for TB, in Russia with some very, very challenging times. And so I have an appreciation for her. She's unparalleled in her tenacity and her experience in this domain. So she was our first choice, to be honest, to talk about science and diplomacy. And what's wonderful about Gail is that she has Russian colleagues here who will speak next and give another side of the story. So without further ado, I will test my own ability to load the proper PowerPoint. And Gail is here. Dr. Gail Cassell. Is that the right slide? So this is my first time-saving measure. Okay. Gail, the floor is yours.
So how many of my minutes did you use, Jason?
I used none of your minutes, Gail.
Okay, all right. So let's see then. I want to talk to you about drug-resistant TB, but just to give you a definition of the challenge, because my title had challenges and opportunities. The issue with TB is the oldest infectious disease known to man, yet today 1/3 of the world's population, 1/3 is infected with Mycobacterium tuberculosis. And 2 billion people, that means, are infected worldwide, and 1 in 10 of these will actually develop disease. 12 million of these are infected also with HIV. And if you look at the productivity lost annually, it's estimated, which is a gross underestimate, of $12 billion, with workers losing at least 3 to 4 months of their work time. So for many reasons, it deserves attention. And given the comments that were made this morning by Rush about the significance of antimicrobial resistance, I would put drug-resistant TB at the top of the list for many reasons that you'll hear in just a minute. But to let you know that when I'm talking about drug-resistant TB, unlike most people that talk about antimicrobial resistance, we're not talking about an organism resistant to a single drug. But drug-resistant TB usually means that it's multi-drug resistant TB, being resistant to up to 10 drugs, but in particular 4 drugs that are the standard regimen for treating MDR. And in 2006, it was observed that we not only have MDR, but XDR, extremely extensive drug-resistant TB, which just takes the numbers up more. And then in 2010, 11, and 12, it began to become very clear in those countries that we're looking, we do actually have totally drug-resistant TB. We can talk about that more. So the comments that I'm going to make, flying through my slides, are based on 2 main experiences. One is a challenge that was posed to Eli Lilly 1 month after I arrived at Lilly. So we initiated an MDR TB partnership that involved tech transfer that Jason has already referred to, along with a lot of other things. And then in 2000, because of obvious reasons related to resistance and increasing resistance, we launched a not-for-profit TB drug discovery initiative in partnership, I might add, with the National Institute of Allergy and Infectious Diseases and the Institute for Infectious Disease Research in Seattle. I'm also going to talk to you about the experiences that I had in the Institute of Medicine Drug Forum that I helped to establish in 2005. And part of the motivation was to use the challenges and barriers to access to drugs for treatment of multi-drug resistant TB to learn a lot of lessons about what we needed to learn in terms of drug development in general. So one of the initiatives was a multi-year initiative, which is highly unusual for IOM. It was also a global initiative, again, very unusual for IOM, and I am going to talk to you a little bit about what we learned in that global initiative with respect to the IOM Drug Forum. Just to give you a little bit of history with respect to multi-drug resistant TB and the importance of the science that underlies the policy and these issues that we decide to take on globally. In 1997, 1 month after I got to Lilly, I got a phone call from our CEO that said that he had had a call from one of our board members that Howard Hyatt, former dean of the School of Public Health at Harvard, had called and said he had a real problem on his hands. 2 young faculty members were trying to do a drug treatment trial in Lima, Peru, in the slums. They had lost a friend, Father Jack, a priest that was working in the slums. He came back to Boston, was treated, the treatment failed, and they were out to prove to the world that if it were done correctly, using the appropriate drugs, that one could actually cure patients with MDR TB. So I'm gonna tell you how they did that. Now, it's important to know that those 2 young physicians were both just beginning their careers at Harvard. This was, remember, 1997. One was Jim Kim, who's now president of the World Bank, former president of Dartmouth, and the other is Paul Farmer, a university-wide professor at Harvard. And we could spend the rest of the day talking about both of these individuals and their leadership. Both were involved in the IOM initiative and planning and well, a lot of background work that had to go before it. The real reason that IOM decided that we would dedicate so much time and effort to this issue is that if you started tracking the WHO reports on the burden of MDR TB, you notice the numbers never changed from World TB Day for the first 5 years. It was always 500,000 new cases of MDR TB. Being a microbiologist, I said no way that you can have an infectious disease that's spread by the aerosol route and the number of cases remain the same. So the question was, what is the real challenge? And what had happened based on the work of Jim Kim and Paul Farmer is that Lilly did go ahead and provide drugs for them to finish their drug trial, and essentially for the first time they were able to prove that you could effectively cure patients with MDR TB. So the question was, for the IOM, what is the real burden of disease related to MDR TB? What are the policies in existence in the countries? We decided to focus on the BRICS. The reason for that is because, believe it or not, 2/3 of the world's cases of MDR TB are in the BRICS countries, with Russia, India, China, and South Africa being the 4 highest burden countries, and so that's where we spent most of our effort. We also held a workshop on the drug supply chain, which is an unbelievably challenging area and probably is the biggest barrier to access that there is, and involves a lot of policy, and one heck of a lot of diplomacy is needed there, but we don't have time to talk about that. I just want to emphasize, what did we learn? And what we learned was what we expected, and that is the magnitude of MDR TB is grossly underestimated. And so even if you accept the 500,000 new cases each year, and then you appreciate, as we learned at our workshop in India, and actually begin to do the calculations, that WHO through the Green Light Committee was only treating 0.5% of those newly diagnosed cases. You can do the calculations, and if you believe the data, you could assume that well over 10 million patients with MDR TB were still infected and hadn't been treated. So less than 0.5%, that's important. What we also learned was, in contrast to popular belief, and we would say dogma, but was a policy on the part of WHO, was the fact that person-to-person spread of MDR TB was occurring at a much higher frequency, and by the way, XDR TB, and by the way, TDR TB, than anybody ever imagined. And in 2012, China, CDC, bravely published in the New England Journal that 78% of the MDR-TB cases in China had no prior history. The patients had no prior history of having been treated for MDR-TB, much less having even been exposed to somebody with MDR-TB. A huge awakening, and clearly this now has changed with a lot of data to back it up. But what I want to point out to you is that in 1994, the WHO TB program recommended that treatment of MDR-TB should be a low priority for the TB programs in country, particularly those in developing countries, because the drugs were too high, and by the way, that the prospects for cure were limited. And MDR-TB is too expensive to treat, and what's worse, it detracts attention and resources from treating drug-susceptible disease. Okay, that was a statement in 1997, and it was in 1998 that Jim and Paul completed their trial in Lima and proved that if done correctly, you could effectively cure 87% of patients infected with MDR-TB, and other groups have gone on to prove it in spades. In 2006 was when the first case of extensively drug-resistant TB was reported in KwaZulu-Natal, and what was really disheartening was that right before our Beijing meeting, the reports of totally drug-resistant TB in India were being released in the public media in particular. The Indian government as well as WHO were saying, don't believe it, totally drug-resistant TB doesn't exist. Well, it depends on how you define it. And part of that definition that it doesn't exist was we have new drugs in the pipeline. Well, new TB drugs require, and most drugs require at least 10 years for development. So to say that they're not totally drug-resistant because new drugs are on the horizon, to me, doesn't make sense. And so it's important, I think, that we confront the reality. So at the Beijing meeting, we actually had Dr. Udwadia come and present his data and plead his case. What is really the other most important finding, I would say, in the series of meetings in the BRICS was in the South Africa meeting where Gary Rubinson made a presentation on pediatric MDR-TB. We concluded that pediatric MDR-TB was a silent epidemic, mainly because WHO was not reporting cases of MDR-TB in children less than 14 years of age. Well, as it turns out, the biggest peak of MDR-TB in children is between 0 and 14 years of age. What was important is that Gary presented data that also, just like adults, 85% of those of the infants and children had no prior history of TB treatment, meaning it wasn't acquired resistance or mismanaged treatment, but rather that they must be acquiring it by aerosol. In fact, Jim and Paul and other colleagues at PIH did a study in Russia, in Tomsk, that proved the highest risk factor in that population in Siberia was hospitalization or institutionalization of patient. In other words, if you had a prior history of being in the hospital, that was one of your with patients that had MDR-TB. In fact, that was your biggest risk factor for developing MDR-TB. I want to just mention quickly two very important outcomes of the series of IOM meetings. One was following the India workshop. In fact, we had something established that two young assistant professors, one at Harvard, one in India, developed. It's called the Sentinel Project. It's up and going and very, very active today with global participation, including in a very major way from Russia. And the bottom line is, beginning from our first meeting in 2008, where Dr. Gail from Shanghai presented in China, that he had new molecular data where he could prove that, in fact, MDR-TB was being transmitted from person to person by aerosol, and then a lot of data leading up to the Beijing meeting, again to confirm in the China publication in the New England Journal that person-to-person spread, in contrast to the dogma and the policy that MDR-TB strains were less physically fit and were not transmitted as easily. Therefore, infection control was never a high priority until the outbreak of XDR-TB. And of course, now that all of the other data are known about how easily it is spread. So point-of-care diagnostic becomes extremely important to prevent spread. Gene Expert has been wonderful, although many challenges, and we all know and have concluded we need something else. So one of the other major initiatives that actually didn't arise by IOM starting it, but a group that had been participating in these meetings got together, and in late December of 2011, we actually established something we call the TB Resist Consortium. It's a global genome sequencing consortium and also a consortium to develop predictive analytic tools, but with the idea being that until you have the full spectrum of antimicrobial resistance, you cannot prescribe the right drug for the right patient at the right time. So looking forward to new diagnostics, we thought this was extremely important. I would just point out that Maria Giovanni and Carol Heileman at NIID were very supportive of this effort, and especially since there were less than a handful or 2 handfuls of whole genome sequences of drug-resistant TB, Mdr Tb in the public domain at the end of 2011. So big need for more data. The number of members in this consortium, I must admit, were very selective at the outset because we wanted primarily data from the BRICS countries and a few others. I won't take time to go through all of them. You'll hear from our Russian colleagues this morning, which are a very important component of it. But mainly through efforts through the Fogarty International Center, we were able to get permission to have 2 partners in Iran. Even before the UN discussions began between the US and Iran, they've been extremely important. And by the way, Iran was the first country to report the existence of totally drug-resistant TB, and that was in 2009. And just like most of the other countries, guess what? They were in patients that had immigrated into Iran, not from within, which turns out to be the most common. We have 3 different sequencing centers that have contributed heavily to the sequences that are available. The Broad, that's supported primarily through NIID, but China CDC has just, in fact, completed 50 whole genomes that they are going to be sharing with us in the coming weeks. And then the Russian Academy of Sciences doing their own sequencing, but participating actively in sharing. Last thought I want to leave with you, and that is 1 week before the IOM workshop in Beijing, there was a very important meeting held of the Ministers of Health of the BRICS. The title of our IOM workshop, by the way, we were unaware the Delhi meeting was going to do what it did, but was that the realities of multi-drug resistant TB, the BRICS lead. And so it was a big belief that the BRICS should lead because of their emerging economies, but also their disease burden. But we say that the New Delhi meeting of the Ministers of Health of the BRICS countries, which was only their 2nd formal meeting, was a watershed for TB control. Why? Because they made a declaration which was read to us at the Beijing meeting, actually by the Minister of Health of Brazil. In that they got together, they said, drug-resistant TB is one of our biggest problems. We're going to collaborate, we're going to cooperate, we're going to establish a consortia of TB researchers to address the issues related to multi-drug resistant TB. And by the way, work to provide high-quality drugs of the existing drugs to treat them. Why is this consortium concept so important, and the communique from Delhi, from the Ministers of Health, so important? It's so important that unlike most drug-resistant organisms, to effectively treat XDR and MDR, you need not only just 1 new antibiotic, but you need 4 new antibiotics, preferably different mechanisms of action, with each one of them costing over $1 billion to develop. So the only way we'll succeed, both in terms of time and money, is through collaboration and cooperation. And primarily, we still would argue that the BRICS should take the lead. So we have a BRICS initiative that hasn't really been launched yet, but with an intention to carry the lead. Just to let you know, this is a photo that appeared in Science. It was actually because a group of us got together and established an Mdr Tb diagnostic lab in North Korea with funding from the Nuclear Threat Initiative and investigators at Stanford. It's up and running. Had people visit just in the last months, and it's going good. And there's plenty, as you might imagine, of drug-resistant TB, multi-drug-resistant TB in North Korea that have actually now been published. And excitingly, just at the beginning of March, the first ever Asian African Congress of Mycobacteriology took place in Iran and was organized by our collaborator, Patricia Farnia. Was very successful by everybody's count. There were 250 people there, mainly from the Middle East and Africa. And approximately 2 weeks ago, at the newly launched Harvard Center for Global Healthcare Delivery in Dubai, we focused on, guess what, pediatric MDR TB and a consortia of countries, including Russia, South Africa, China, and a cities project to implement all of the new knowledge in terms of actually trying to prevent MDR TB and spread, particularly in households by infected children. With that, I'll quit. And Jason, I hope I was at least somewhat within limits.